Good day. I'm Dr. Ian Kwa. I was tasked to discuss on when and how to treat chronic hepatitis B. The objectives of my lecture is first, to discuss the current HSP guidelines on treatment. Second, to discuss how to monitor patients on treatment. Last but not the least, to discuss treatment endpoints. In 2014, the Hepatology Society of the Philippines embarked on the development of consensus statements on the management of hepatitis B with the primary objectives of standardizing approach to management, empowering other physicians involved in the management of hepatitis B, and to advance treatment subsidy by the Philippine Health Insurance Corporation. So our clinical question is when to start hepatitis B treatment. So the determination of whether to initiate hepatitis B treatment requires weighing the benefits against the risk. The key risks include the potential for adverse effects of the drug and the development of drug resistance. By contrast, immediate benefits of the antiviral treatment would be suppression of HBV DNA and hopefully normalization of ALT and the liver function. Long-term benefits include prevention of liver cirrhosis from this chronic infection and possibly the prevention of liver cancer. So, we have to really consider the likelihood of adverse outcome without treatments and the potential for treatment to prevent them. Individually, we must consider the risk of cirrhosis and liver cancer in the patient in the next 10 to 20 years. The following are the goals and benefits of hepatitis B treatment. First, to suppress the HBV replication. Second, to decrease liver necrosis and inflammation. Third, to reverse liver fibrosis and importantly, to prevent progression to cirrhosis, liver failure, and liver cancer. Who should be treated? So this is not a question of who to treat, but when. Whether you treat them now or just monitor or treat later when indicated. So we have to remember that all HBV carriers are potential treatment candidates. A patient who is not a treatment candidate now can be a treatment candidate in the future depending on the changes in the HBV replication status and or the stage of the liver disease, and the availability of new or improved treatments for chronic hepatitis B. So this is the indications for treatment based on the 2014 HSP consensus on hepatitis B. First, we have to start on treatment if the patient has persistently elevated ALT levels more than 2 times the upper limit of normal over 3 to 6 months and a HBV DNA level more than 20,000 IU per ml if HBe antigen positive patients, and more than 2,000 IU/ml if HBe antigen negative patients. We also need to consider treatment for patients with advanced fibrosis or at least moderate inflammation, and biopsy should be treated even if the ALT is normal. Treatment should also be initiated in cirrhotic patients with detectable HBV DNA regardless of the level of the serum ALT. So this table shows to us the treatment criteria for chronic hepatitis B based from the treatment guidelines from the different societies around the world. So HSP, depending on the HSP guidelines, if the patient is HB antigen positive, we have to start treatment if the ALT is more than 2 times the upper limit of normal and the viral load should be more than 20,000 IU per ml. And for E antigen negative patients, the HbA should be more than 2,000 IU per ml and the ALT should be 2 times the upper limit of normal. The following cases should be where in which treatment should be initiated. It's patient presenting with life-threatening liver disease such as acute liver failure, decompensated cirrhosis, and patients with severe flare of chronic hepatitis B. And also, we have to start treatment on compensated cirrhosis with high HbA because there's increased risk of liver cancer and liver failure in the near future. And also, we have to start treatment in HBeS antigen patients who will be starting immunosuppressive therapy. And last but not the least, non-cirrhotic patients at high risk of progressive liver disease. This table shows to us the current approved anti-HBV agents, the antiviral drugs, namely pegylated interferon alpha 2A, entecavir, tenofovir. These are preferred first-line agents, and the rest such as interferon alpha 2B, lamivudine, adefovir, telvivudine, and clevudine. So how do we differentiate the use of pegylated interferon versus nucleoside and nucleotide analogs for patients with chronic hepatitis B? The advantages of using pegylated interferon is that the patient will receive the pegylated interferon for a finite course of therapy for 12 months. So there's no reported resistance with the use of pegylated interferon, and there's higher rate of HBe antigen loss as well as HBs antigen loss with the use of pegylated interferon. The disadvantage of using pegylated interferon is that you have to administer it subcutaneously weekly. Patients will develop frequent adverse events. And you also need to remember it's contraindicated in patients with cirrhosis, in pregnancy, patients with acute hepatitis B, and immunosuppressed patients. On the other hand, the use of nucleoside-nucleotide analog, the advantages is that you can take it once a day orally. There's infrequent adverse events. The disadvantage is the patient need to take this for a longer period of time or indefinite treatment, and there's potential for drug resistance, and the long-term safety is unknown. With regards to the safety and efficacy of the use of nucleoside and nucleotide analogs, so based on this table, we have 5 available oral antiviral agents with the different characteristics such as antiviral activity, its safety, and the rate of antiviral resistance. So this has been graded to plus to plus 3, indicating more potent antiviral activity and better safety profile. So based on this table, entecavir and tenofovir are preferred first-line therapy together with pegylated interferon because of its high antiviral activity. There's less side effects and very low rates of antiviral resistance. This is a common question that usually asked by our patients in our clinical practice. How efficacious are currently available antiviral therapies? As I've shown you, these drugs are potent viral suppression but not eradication. There's lower rate of HBs antigen loss. There's some evidence that these antiviral agents can reverse hepatic fibrosis and even cirrhosis. And most importantly, it can prevent progression to liver failure and to a smaller extent, liver cancer. You also need to remember that the current treatment controls but does not cure the HBV infection. To summarize, with regards to the management of chronic hepatitis B infection, if you have a patient who tested HBs antigen positive more than 6 months, we need to test and perform the following examination. such as HBe antigen, anti-HBe, HBV-DNA, the ALT level, and as well as the liver ultrasound. If you suspect the patient with cirrhosis, you have to check the alpha-fetoprotein. And if we suspect other co-infection, if they have risk factors, we also need to check the anti-hepatitis A levels. And if they're negative for hepatitis A, we have to vaccinate them for hepatitis A. And also, we also need to check the anti-HCV as well as the HIV status. If the ALT level is less than the upper limit of normal, with HBV-DNA less than 2,000, so this patient has inactive HBs antigen carrier status. So this patient does not need any treatment. All we need to do is we have to monitor HBs antigen, ALT, the HBV-DNA, the alpha-fetoprotein every 6 to 12 months. If the patient has E antigen negative infection with viral more than 2,000 IU per ml, with ALT more than 2 times the upper limit or normal, or significant biopsy, we have to consider this patient on treatment. On the other hand, if the patient with HBe antigen negative infection with ALT less than 2 times the upper limit of normal, all we need to do is we have to check the ALT and the viral load every 3 to 6 months. And consider liver biopsy for patients more than 40 years of age and family history of liver cancer, and we have to start treatment as needed. On the other hand, if the patient is presenting with E antigen positive status with viral load more than 20,000 IU per ml with an ALT more than 2 times the upper limit normal or positive biopsy, we have to start this patient on treatment. And if the patient has E antigen positive patients with ALT less than 2 times the upper limit of normal, all we need to do is check the ALT and the viral load every 3 to 6 months and consider liver biopsy for patients more than 40 years of age and family history of liver cancer. We have to treat them as needed. So this slide shows to us the different responses to hepatitis B treatment. First, the virological and serological response. So there should be a sustained decrease in the serum HBV-DNA to undetectable levels. And over time, we also need to look at the E antigen loss and seroconversion to anti-HBe applicable to HBe antigen positive patients only. Last but not the least, the ultimate goal is S antigen loss over time. The second important response is the biochemical response, wherein the ALT levels should be decreased to normal levels. Last but not the least is the histological response, wherein there's a decrease in the inflammation score, which is seldom assessed in clinical practice. So these are the treatment endpoints for chronic hepatitis B. For E antigen positive chronic hepatitis B patient, we expect once the patient is started on treatment, there's reduction of HBV-DNA to normal levels, there's normalization of the ALT, and E antigen loss over time with anti-HBe seroconversion, and the ultimate goal is HBs antigen loss and seroconversion. On the other hand, for HB antigen negative chronic hepatitis B infection, we expect once they start on treatment, there's reduction of HBDNA levels to undetectable levels with normalization of ALT, and ultimately the patient should have HBs antigen loss and seroconversion. So this is so important for patients with HBe antigen positive infection on treatment. So the HBe antigen seroconversion is a seminal event. It will signal an improved level of immune control. It is often associated with ALT flare followed by normalization, a decline in HBV A to undetectable levels, and reduction in the inflammatory and injury in the liver. So this is highly desirable because it's an important goal of antiviral therapy for patients with chronic hepatitis B HB antigen positive patients. On the other hand, HBs antigen seroconversion is the most reliable marker of immune control. It is often associated with excellent long-term prognosis if cirrhosis is absent at the time of clearance. These are the parameters for monitoring treatment success. We have to check the ALT levels every 3 months. The HbA should be checked every 3 to 6 months on treatment, then every 6 months after 1 year of treatment to check first and foremost the compliance and the treatment response of the patient, as well as checking whether this patient has drug resistance. In addition, we also need to check the E antigen status as well as anti-HBe status every 3 to 6 months for HB antigen positive patients to check on the HBe antigen seroconversion. And last but not the least, we also need to check HBs antigen level every 6 to 12 months for HBe antigen negative and once HbA level is undetectable. So once the patient is successful with the treatment, we also need to check every 3 months the serum viral markers to check whether the patient has relapsed to the treatment, which I will discuss in detail later. The most important clinical question asked by our patients when we start them on oral antiviral agents is when to stop nucleoside-nucleotide analogs. For non-cirrhotic patients who are HBe antigen positive, after confirmation of HBe antigen seroconversion, all we need to do is we have to add additional 12 months on consolidation therapy before stopping treatment. On the other hand, for non-cirrhotic HBe antigen negative patients, we have to stop the oral antiviral agents once the patient has confirmed HBs antigen loss. And for compensated cirrhosis, we usually never stop the treatment or the patient will have HBs antigen loss. And most importantly, for decompensated cirrhosis, we do not stop the oral antiviral agents. So how do we monitor patients after treatment? So all patients should be closely monitored to detect viral and biochemical relapse after treatment is stopped. So we have to check whether there's increase or reappearance of HBV with or without reversion from E antigen negative to HBe antigen positive, often accompanied by increased ALT, which can be fatal in patients with advanced fibrosis and cirrhosis. Once the patient has relapsed, we need to restart them on treatment. So this is my last slide for this lecture. When should you seek the advice of an HBV expert before initiating therapy? First, if the patient is treatment experienced, Patients with advanced disease stage, especially decompensated cirrhosis, we have to refer them to a tertiary center with liver transplant service. We have to consider to list this patient for possible liver transplant. And third, if there's concern for antiviral resistance, then patients with HIV or HCV co-infection, patients who are pregnant, and anytime you have concerns about how best to manage a patient. Thank you very much for listening to this lecture. It is my great honor and pleasure. Maraming salamat po. Mabuhay.